So let's start talking about cystic fibrosis. Cystic fibrosis is an autosomal recessive condition. So both parents need to be carriers in order for an offspring to have this condition. Now it causes multi-organ dysfunction. Most of the organs that are involved in this condition are your lungs, the gastrointestinal system and the pancreas, and genitourinary system. Now the name given to this condition, that is cystic fibrosis, is because this condition involves the presence of multiple cysts along with fibrotic changes that occur in the pancreas. So, as far as the etiology is concerned, what happens in this condition is that there is a problem in the long arm of chromosome 7, and this long arm of chromosome 7 actually has got a gene which regulates the CFTR, that is the cystic fibrosis transregulator gene. Now this gene is faulty, and when this gene is faulty, what happens is that the chloride channels, these chloride channels have got the CFTR protein as a part of its structure, and if it is faulty, then it's not properly able to transport chloride across the cell membrane. There are more than 6 categories of mutations on the CFTR gene. The most common is the class 2 mutations, which are also known as the delta F508, in which there is the problem at the 508 position of this gene, particularly that encodes for the CFTR gene. Some of these mutations lead to a mild form of the illness, and some of the mutations that lead to more severe form of cystic fibrosis. So coming down to the pathophysiology, once the CFTR gene is dysfunctional, so what happens is that the CFTR protein is not properly produced. So the chloride channel, which is responsible for transporting chloride across the cell membrane, that is faulty. Why it is faulty? Because the CFTR protein is either abnormal or is either missing. So what happens is that there is decreased movement of chloride across the channel. Now as far as the mucous glands are concerned, or the mucous surfaces are concerned, what happens when the chloride channel is faulty? The cell membrane is not able to push chloride out of the cell, so the chloride remains inside. At the same time, while the chloride remains inside, the defective CFTR protein also causes inhibition of the E voltage gated sodium channels. So what happens? A lot of sodium moves inside the cell. When the sodium moves inside the cell, it takes a lot of water along with it inside the cell. So the secretions in the mucous cells, they become very thick. They are so thick that they remain stuck, and the function that is performed by the mucus, that is clearing of the epithelial or the endothelial surfaces, that is not properly done. So in the mucous glands, the chloride remains inside the cell, and at the same time, because the CFTR gene also regulates the E-neck, that is the E voltage gated sodium channel, lot of sodium goes inside the cell along with water that goes inside the cell. So what happens? The secretions would be very thick and viscid. Now as far as the sweat glands are concerned, the opposite happens over there. So in sweat glands, these chloride channels are responsible for reabsorbing the chloride back into the cells. So when these these chloride channels are faulty in the sweat glands, what would happen? The chloride would not go back inside the cells. When the chloride would not go back, similarly the sodium would not go back inside the cells because of the defective E voltage gated sodium channels. So what would happen? That the sweat would contain lot of sodium and lot of chloride, and that is one of the basis of diagnosis as well, that the sweat contains lot of sodium and lot of potassium. So there would be 2 defects. Number 1, in the mucous cells, the secretions would be very thick, and in sweat glands, the sweat would be very salty because of a high sodium and high chloride content. So what happens is that decreased water content of the thick secretions, it leads to mucus plugging, especially in the lungs, and that would lead to bacterial overgrowth, because thick secretions are a very good medium for bacterial overgrowth. So these children or these people who have got cystic fibrosis, they have increased chances of repeated chest infections. Now coming to the clinical presentation. So it can present either in early life, or it can be picked up in later childhood, or sometimes even in adulthood as well. As far as the early life clinical presentation is concerned, in the newborn, because of the thick mucous secretions, they can present with meconium ileus. And the meconium ileus means that the meconium is so thick that the baby is not able to pass it out. And when the baby is not able to pass it out, what would happen? It would lead to intestinal obstruction. So the baby would be born, and progressively he would get abdominal distension, he would get bilious vomiting, and sometimes it might lead to intestinal perforation as well. Sometimes it also leads to meconium plug, where there's a small part of the meconium which is so thick that the child is not able to pass poo. And in some cases, the parents also say that the baby feels very salty, especially if it is born in hot weather, or if it's born in the summer season, especially in those areas where the summers are very, very hot. In later childhood, it usually presents with chronic chest infections. So that can present with chronic cough, that can present with chronic wheezing, that can present with chronic lung problems. They can present with chronic gastrointestinal problems, like for example chronic diarrhea. And obviously, because the diarrhea is happening for a prolonged period of time, there is not proper absorption of the nutrients. So they go into a condition which we call as failure to thrive, that they are not properly growing. And they can have chronic abdominal problems like abdominal pain, so on and so forth. Now, as far as the manifestation of cystic fibrosis is concerned, cystic fibrosis can present in a variety of ways. By and large, the most common presentation is repeated chest infections. So these children who have got cystic fibrosis, they have got a history of repeated chest infections of one after the other. They can also present with wheezing, they can also present with difficulty in breathing, and they've got a chronic cough as well. As far as the gastrointestinal system is concerned, they would present with chronic diarrhea and failure to thrive, because the pancreas is not functioning properly. Why? Again, because the pancreatic secretions are so thick that they are not able to move out of pancreas into the gastrointestinal system. And you know, the pancreas contains a lot of digestive enzymes. So what would happen, that these digestive enzymes are not spilled into the intestines, and when they are not spilled into the intestines, what would happen is that the nutrients which need these enzymes to be absorbed, they would not be absorbed. So there would be a deficiency of micronutrients and vitamins, especially fat soluble vitamins like the vitamin A, D, E, K. They can be deficient in these children. So these children would be having chronic diarrhea and steatorrhea as well. Steatorrhea means that there's a lot of fat content in the stool. Why? Because the fat is not being absorbed. Again, why? Because the pancreas secretions are so thick that those enzymes, they cannot come into the intestines. Similarly, because of the thick secretions in the genitourinary tract, these kids can develop infertility as well later, obviously in the adulthood. Similarly, they can have other coexisting problems like gastroesophageal reflux disease. They can have chronic abdominal pain. Sometimes they can have co-associated conditions like they can develop diabetes, they can develop thyroid problems. If you examine them, mostly these kids would be of short stature because there is failure to thrive. There might be some nail clubbing because this condition is associated with the clubbing of the nails. They can be anemic, they can have the associated features of multivitamin deficiencies like rickets, like vitamin A deficiency, so on and so forth. They might also become diabetic later in their life, or may also exhibit thyroid problems. But again, by and large, the most common condition presenting features is repeated chest infections. And if you do a chest X-ray, you will see that they've got bronchiectasis changes, which is again a form of obstructive lung problem. And especially if the high resolution CT is done, there will be confirmation of these bronchiectasis changes, because the air is retained and the alveolar septa, they are destroyed, leading to bronchiectasis changes. Now coming to the diagnosis. Now diagnosis can either be done by newborn screening. So in newborn screening, routinely day 5 immunoreactive trypsinogen test is done as part of the GO3 test, and if that is positive, that is followed by confirmatory sweat analysis. So a sweat level which contains sodium chloride more than 60 millimoles per liter, that is confirmatory for cystic fibrosis. So remember, the best screening tool is day 5 immunoreactive trypsinogen, and this immunoreactive trypsinogen is usually elevated, and if it is elevated, then it is followed by sweat analysis, and the sweat analysis must show greater than 60 millimoles of sodium per liter for confirmation of cystic fibrosis. And this test is 95% sensitive. In other words, 95% of those who have cystic fibrosis will be picked up by this particular test. Now as far as the diagnosis is concerned, we need to have one of the two sets of features. So remember, we can just remember it in the form of CNS and CNM. So if one of this CNM SS category is present, like if there are presence of typical features of cystic fibrosis, like for example repeated chest infections, repeated gastrointestinal symptom, or there is a positive newborn screening test, that is day 5 immunoreactive trypsinogen, or there is a history of cystic fibrosis in a sibling. So any one of these three, either a positive screening test, newborn screening test, a history of cystic fibrosis in the sibling, or presence of clinical features, any one of this, plus 2 or more confirmatory sweat sodium levels more than 60, or abnormal potential difference across nasal epithelium. Now nasal epithelium is one of the areas where the potential difference across the nasal epithelium can be measured. Now I told you earlier, if you remember the pathophysiology, sodium moves inside the cell. A lot of sodium moves inside. So when the sodium moves inside, there is less negative voltage outside the cell membrane. So normally this is minus 24.7. So if it is more negative than that, so if it is greater than minus 24.7 difference across the nasal epithelium, that is also confirmatory for cystic fibrosis. So an abnormal nasal potential difference across the epithelium that is more than minus 24.7 millivolt, or if there by genetic testing, if we find 2 or more cystic fibrosis mutations like the delta F508 mutation or other mutations, if they are detected by genetic tests, so one of these, any one of these, so either 2 sweat tests greater which are having more than 60 millimoles of sodium, or abnormal nasal potential difference greater than minus 24.7, or the 2 or more genetic mutations. So any one of these plus clinical features or newborn screening or history of sibling. So if one of these categories are present, we confirm that this child has got cystic fibrosis. So one is screening, the other is diagnosis. You must remember how it is screened and how it is diagnosed. Now once it is diagnosed, then there are certain tests which are done in established cases of cystic fibrosis, because it's a chronic condition, it's a lifelong condition. So certain tests are done at various stages to measure the progress of the disease and to measure some of the complications which are associated with this particular condition. So number one is spirometry. Now spirometry is done when the child is able to do that, and that is done to determine lung function, because with bronchiectatic changes or repeated chest infection, the lungs can be affected to the extent that sometimes it might require lung transplant as well. So it's very important to measure the lung function over a period of time, and that is done by spirometry tests. We also do sputum culture test. If the child is old enough and is able to produce sputum, we do repeated sputum cultures to determine if there are any type of colonization. So the type of colonizations that can occur in this chronic lung involvement in cystic fibrosis is Staph aureus. So their secretions can be colonized by Staph aureus. It can be colonized by Pseudomonas aeruginosa and Burkholderia capacia. So these are the 3 organisms that you must remember that can cause colonization in cystic fibrosis. By and large, the most common is Staph aureus. We also do the high resolution CT scan to establish the degree of bronchiectasis in these children who have got repeated chest infection. To determine the pancreatic function, Fecal elastase is the best screening tool. So the fecal elastase can tell you how much the pancreas is involved and whether these children would need any form of enzymatic replacement therapy like creons. We also do routine blood tests to determine the degree of anemia, because obviously these kids have got malnutrition, they have got failure to thrive, so they can become anemic over a period of time. Another reason that we do full blood count is that if we found neutropenia and thrombocytopenia, it might point towards a condition which might make cystic fibrosis, and that is Schwarzman-Diamond syndrome. So again, that has to be differentiated, and usually in Schwarzman-Diamond syndrome there is neutropenia and there is thrombocytopenia, which you normally don't see in cystic fibrosis. We also do screening for diabetes and thyroid problems, because diabetes and thyroid problems are more common in kids who have got cystic fibrosis, and we have to do growth monitoring because they've got failure to thrive, so we need to know how much they are faltering on their growth parameters, so that some nutritional support can be offered to these children. Now coming down to the treatment. Now, one thing is what we call as a general treatment, and then we call the specific treatment. A general treatment means that obviously because they are more prone to infections because of thick secretions, you have to ensure that they are well hydrated, they have got good nutritious diet, and they are immunized against some of the common diseases which can cause problems in these kids. As far as the nutritional therapy is concerned, obviously because they have got failure to thrive, you need to supplement them with the fat soluble vitamins, you need to give them a high calorie diet, and you have to supplement the diet along with replacement enzymes so that those nutrients can be absorbed by the gastrointestinal system. Now, one most important thing is the pulmonary therapy. So in pulmonary therapy, because the lungs are very much involved in this particular case, so number one is the inhalation therapy. Most of them they are colonized, and they have got obstructive changes, so inhalation therapy in the form of bronchodilators as and when needed, that is a beta-2 agonist, salbutamol or corticosteroids, in order to break down the thick secretions, the recombinant DNase, inhaled DNase, because that has to break down the viscid secretions. That can also be helpful. Similarly, they would need antibiotics because they are colonized by bacteria, Staph aureus or Pseudomonas aeruginosa. So if it is Staph aureus, you can give them flucloxacillin. If it is Pseudomonas, ciprofloxacin or other antibiotics which might be effective. So once you have done the sputum analysis, the culture and sensitivity is also done to see which antibiotics are effective in those conditions. Those antibiotics can then be given. Similarly, chest physiotherapy is also important so that the routine secretions can be brought out. The more these secretions are brought out, the lungs and the airways would be clear, and the chances of future infection would go down. Then there are certain types of emerging therapy which actually help in the functioning of the chloride channel. You know that the CFTR protein is defective. So CFTR potentiators are some of the drugs that help in regulate this protein, though despite it is deficient, but it can still be helped by some of the drugs, so that the sodium channel and the potassium and the chloride channel, which are not working properly and retaining the secretion inside, if you give them these drugs, they would potentiate the chloride channel. So when they are just potentiated, it would start working and it would start throwing chloride out of the cell membrane. These drugs are ivacaftor and lumacaftor. And research has shown that lumacaftor and ivacaftor, which are actually CFTR potentiators, they work very well if the children who have got cystic fibrosis have got the delta 508 mutation. So it helps very much in the cases where there is a confirmed delta 508 mutation. So these are emerging therapies, and they are known as life-changing therapies because you give them this drug and their chloride channels become normal, and when they become normal, chloride would go out, sodium would be outside of the cell, and these secretions would again become normal instead of being thick. But these are very expensive drugs, and they are not used in all cases. They are used in specialized centers by specialized pediatricians who are experts in the management of cystic fibrosis. And if everything else fails, then obviously lung transplantation has to be done, which is again done in very specialized tertiary care centers. So this was the overall ambit of the treatment of cystic fibrosis, which is basically multi-dimensional, and it requires a multidisciplinary team to manage them. So we would need the pulmonologist, you would need the nutritionist, you would need the gastroenterologist, and probably you would need the chest physiotherapist as well. And together they work as a team to manage the different problems which arise in cases of cystic fibrosis. So this was a short lecture about cystic fibrosis. I hope you have understood. Still, if you've got any questions, you can put it down in the comment section below, and I will try my level best to answer them as soon as possible. Hope you have liked this video. Do give it a thumbs up and share it with your friends. Thank you very much, and bye-bye.